What's up everyone, it's your boy Mus Tutor. Welcome to another Mustat. So today we'll be discussing an ECG I posted in my story earlier today, a 21-year-old gentleman who presented with DKA, and this is the ECG. So I think first impressions. Something is very abnormal about this ECG, but as with anything in medicine, being methodical is the best. So let's look at the rate. So the rate is we count the number of QRS complexes and times it by 6, why 6? This is a 10-second ECG, 10 times 6 is a minute, so we're going to count 15 complexes times 6 is equal to 90. Then we're going to look at the rhythm. So is this regular or irregular? Just from the eyeball test, it looks regular to me, but if you want to do a paper shift method, I've done it and it is regular, right? Then we're going to look, is it sinus rhythm or not? So we're going to look at the P waves in our inferior leads, and can we see that all of these are positive? And then we're going to look at the P wave in AVR, and we can see that that's negative. So that means that this is in sinus rhythm, and sinus rhythm essentially means that your impulses originate from your SA node, but I'll make a video about that as well. So then we're going to look at our P waves, and our P waves are not taller or broader than 2.5 small blocks, so there's no issues with our P waves, no P mitrale or P pulmonale. Then we look at our PR interval. So if we notice our PR interval, let's just zoom in over here, it's not very clear, but we can see from there to the start of the QRS complex, right, is less, to the start of the QRS complex is less than 3 blocks. And our normal PR interval is 3 to 5 blocks. So there's PR shortening, right? So that's the first abnormality that we've picked up. Then we look at the QRS complex, and it's obvious to see the QRS complexes look a bit strange. And what is the strange part about them is their width, right? So they look like they are broad and regular, right? We're going to ignore looking at the axis for today because we'll deal with that in another tut. But there's an important part about the morphology of the QRS complexes that we can see. And I just want to highlight that to you, that can you see that this is this initial slurring followed by a fast upstroke, right? So initial slurring, and then there's a fast upstroke, initial slurring, fast upstroke. So I just want you to pay attention to that and bear that in mind, because that is what we call a delta wave. But I will explain that just now. Then we're going to look at our ST changes, and we can see that there's a lot of ST changes here, right? So we can see that there's ST elevation in our high lateral leads, so you can see if that's the isoelectric line, there's ST elevation there. It also looks like there's some degree of ST elevation over there, and then most of the other leads, it looks like there's ST depression, right? ST depression, ST depression, ST depression here, ST depression there, right? So the question is this patient having an infarct? And you must always be wary if you're seeing changes in all of the leads across the ECG that there's something else going on. So just bear that in mind. There could be something like a main stem infarct where you can have ST elevation in AVR followed by ST depression in the other leads, but we'll deal with that later, right? For now, just think there should be a few alarm bells ringing in your head. Short PR interval, delta waves, pseudo-infarction pattern. We need to be thinking about something. And if we put all of these things together, then the answer is that this patient has what we call Wolff-Parkinson's White, or an accessory pathway. So let's explain what that is. Wolff-Parkinson's White is a syndrome that refers to the presence of an accessory pathway or congenital accessory pathway through the annulus fibrosus or the cardiac skeleton, which allows the ventricles to be pre-excitated. So I've drawn a diagram over here, right? So if we just have to annotate the normal electrical impulses in the heart, we have our SA node, and then you have impulses traveling towards the AV node, and then you've got your bundle of His, and then you've got your right and your left bundles, right? So that's how it normally conducts, right? The problem with Wolff-Parkinson's White is that as these impulses are traveling through the atria, right, normally they aren't able to jump across and cause ventricular depolarization. But with Wolff-Parkinson's White, these impulses are able to travel through this accessory pathway. So what ends up happening is that we get this classical delta wave, and I'm going to explain how that happens. So we've got our P wave and then we've got our initial slurring. So let's explain what happens to that initial slurring. So as these impulses travel from the SA node to the AV node, they get delayed at the AV node. Remember, the AV node's one of its functions is to delay impulses to allow for sufficient ventricular filling so that the ventricles can be filled with enough blood to eject to the lungs and the body. So while that delay is happening, these impulses are traveling along and they very happily say, oh cool, I can actually go through here and to the ventricle. And they cause myocytes to depolarize, right? But the problem is that these myocytes are depolarizing talking to the next one. So it's as if I wanted to tell everybody that I made this tut, I wouldn't tell my sister, then to tell my brother, then to tell their friend, to the next friend. I'd try to send an email out to everybody and everybody to get the notification at the exact same time. So that's a bit of an analogy of specialized conduction tissue versus going from one myocyte to another. So normally we get narrow complexes because we're using this lovely specialized conduction tissue, which is our bundles. And it also explains why if you have a bundle branch block and this specialized highway that we have is not working, you get broad complexes. So you get a broad complex or the initial slurring because there's no specialized conduction tissue in this region over here. It's just going from one myocyte to another, and that depolarization is slowly spreading. And then you get that fast upstroke because you've got the AV node kicking in and all of our specialized conduction tissue causing the rest of the ventricle to depolarize. And then you have completion of our QRS complex. So that's why these patients get what we call a delta wave, right? The other important thing to note with these patients is that they are prone to developing atrioventricular re-entry tachycardias, so AVRTs. So they often have a history in childhood of palpitations, and what happens is that they develop re-entry tachycardias where you have impulses that travel down the AV node, right, and then back up the accessory pathway. And then it forms a re-entry circuit like this. And every time that circuit spins around, it causes depolarization. And it goes very fast, and that's why they get a tachyarrhythmia. And I'm not going to say more than that at this point, but that's what they can be prone to develop. When those patients come in with AVRTs, then you're going to do your vagal maneuvers and so we'll just quickly talk about them. Vagal maneuvers can be like a right-sided carotid massage, putting their face in cold water, but there's a trial called the REVERT trial that looked at a modified Valsalva maneuver, and what you do is you basically give the patient a 10 ml syringe, you ask them to blow into the syringe when you tell them, and they need to produce 40 millimeters of mercury in order to move that plunger. And as soon as you see the plunger moving, you having them sitting up while this is happening, and then you drop their head down and you lift their legs up. And the trial says that there's a 43% effective vagal nerve blockade, which should block this AV node and hopefully break this re-entry circuit. What is the vagal nerve? The vagal nerve is a parasympathetic nerve that supplies the AV node. And remember, you've got your sympathetic on the one side and you've got your parasympathetic on the other side, and if we're blocking the parasympathetic side, then sympathetic is going to dominate, and basically we're trying to block this AV node, and in doing so break this re-entry circuit. So that's why we do a vagal maneuver with them. You can also use drugs like adenosine 6 milligrams or 12 milligram flush, but we'll talk about that at a later stage. The other important thing is that you can have re-entry circuits that go in the opposite direction, right? So in this direction. And if that happens, it can be very dangerous because you can have an arrhythmia like an atrial flutter that is in the atria and gets conducted down this accessory pathway. And these cause very fast tachyarrhythmias, very dangerous tachyarrhythmias in these patients, right? One other thing to note is that you get two different types of Wolff-Parkinson's-White. You get type A and you get type B. All that means is type A, it causes left-sided accessory pathways, like this one I've drawn here, and then type B is right-sided accessory pathways. Type A will have your positive delta waves in all your precordial leads with an R to S ratio in V1 over 1, and type B will have negative delta waves in most of your in V1 and V2, right? So it's just a way of distinguishing them. I don't think it's clinically very relevant for us. Maybe for cardiologists it's relevant because it helps them localize where the accessory pathway is for ablative therapy. Right. The only important last point that I want to leave with you guys is that it's important to recognize that this is Wolff Parkinson's white, because I think it's a little bit more common than you think. You will come across patients with it, and it's important to note that this patient doesn't need lysis and shouldn't also receive adenosine, right? Because what is adenosine? Adenosine is an AV nodal blocking agent. So if this patient has this normal conduction that's happening, let's just draw it again. If they have this normal conduction that's happening through this accessory pathway, right? And so normal conduction coming here, and then they have these jumping through there, and they've got these delta waves very happily, P, right? And they've got these very happy, nice delta waves, right? And now you go and give them an AV nodal blocking agent, and you say, we're going to block this AV node. What you can actually end up doing is causing all of these impulses to travel through the accessory pathway only, and can actually push them into an arrhythmia. So patients with Wolff Parkinson's white, the important take home is that they have delta waves at baseline. So if you and I, if we don't have Wolff Parkinson's white, we've just got normal QRS complexes, narrow QRS complexes at baseline, they have delta waves. Cool. Hope that wasn't too long, and hope you guys enjoyed. Feel free to ask comments in the section below, and yeah, like and subscribe.